Well, good evening. We're back looking at the topic of elimination. It's Colleen Hargraves, and I'm going to try to make this short and sweet because we did have last week where we went over this topic fairly in depth on Tuesday and Thursday. So let's just look at these slides and, let me try to remind you of a few things. When you look at page 895, it's going to tell you a little bit about some important aspects of these medications for nausea. So for upper GI, don't think that, we just want to treat symptoms without looking for underlying causes. We need to make sure we're looking at the underlying causes. That's really important. Although we're very grateful that we have these medications today. I think I gave you the wrong, let me see if this is the right page number. Yes. Okay, so when you look on 894, it has two warnings for you, drug alerts, and metoclopramide, Reglan is one that we talked about in class. That's important. When you look at some of the other ones too, just looking at the drug categories, it does show you that they come from, they each have different drug actions and mechanisms. So we do have quite the selection, and we do have to be careful. Things like even compazine, is not appropriate for head injuries. So, they're good medications for some conditions, but not for everybody. So that's why we have to have a variety. Okay, so treating nutritionally, making sense, not giving them too much advancement in their diet if they are sick, giving them clear fluids and then progress them to full, before you get back to a regular diet is very important. And let the stomach rest and recover. If it's just an acute kind of gastritis or something from food poisoning, you don't know what it is, so you have to really figure out what it is first. Okay, now with GERD, we know that that's very common, from birth to advanced age, we have it. And this is, most of the time we do manage it with lifestyle modifications and nutritional therapy, but you do want to say, well, in cases where it gets advanced, what do we do? And we do have options to treat it, and it's wise, because if we don't treat it and try to get a handle on it, it can progress to esophagitis and, worst case, Barrett's esophagus. So the PPIs are helpful at helping the body heal some of these conditions before they advance, or the H2 blockers as well on the antacids. So look at those as well. In pediatric upper GI esophageal disorders, we know that if there's a narrowing or some kind of fistula happening, the esophageal atresia, these are conditions that if a child is coughing, choking, it could even be their own saliva, it doesn't even necessarily have to be related to food, that would be a medical emergency. And yet it's stemming from the upper GI, it's not from the respiratory. So that's why these conditions definitely need to be teased out to make sure that the proper intervention is made. And birth defect, rare but does happen quite often enough, is the cleft palate, cleft lip. It can happen bilaterally too, not just on one side. And this can lead to nutritional deficits and problems, because you need special feeders to help these children take in nutrition. So that's why it's really important that they get access to some kind of surgical repair. And again, in the United States, it's not difficult, but other places of the world, that's why you have Doctors Without Borders and places that go out and do these medical missions, because these children many times would not be cared for in the same way we might try to care for a child with this kind of challenge. And that's sometimes cultural too. They might believe that there was some evil nature to this child. So that's the sad when you think of the old world view. But then there's modern issues where medications have created some of these teratogenic side effects, and so it's not something we have to overlook, but to be aware of, and make sure we educate people not to get pregnant if they're using Accutane, because this is one of the side effects that can happen. There's many more, and many more severe than this. Even some anticonvulsant medications can contribute to this. Gastritis, this is an inflammation of the stomach lining. We know that it's acute, chronic. We have drugs that contribute to these things. So you look at the list over here and you see that, this is pretty common, okay? We also know that the medications are going to be very similar. So in the GI realm, we're basically either going to try to stop the acid or neutralize the acid. That's kind of the approach. If we know somebody is using alcohol to excess, then we have to really do an evaluation to find out if this is part of the contributing to the problem. Otherwise, we can take care of it and they're going to come right back. Okay, spicy foods. There are times people really do eat things that are probably should not be eating. Anybody should be eating. I mean, seriously hot, spicy, damaging foods to the gut. All right, so we have to really do an assessment on that. Peptic ulcer develops usually when you have a series of gastritis happening to you that you're not taking care of, and ulcers can form. So we definitely need to talk to people about their, incidence and try to look for ways to prevent this. But in here you have, again, the drug therapies that you can look through. We're going to just, again, talk about stress management, talk about good nutrition, and also try to educate them as to the danger of an ulcer not being treated can lead to a perforation or hemorrhage. People can have a GI bleed. And again, this is upper GI, okay, because we're talking about the stomach. And that case study with the gentleman, some of you missed it because you were thinking it was a duodenal ulcer, which would not be upper GI, that's lower GI. But the upper GI, the reason why was because he abused alcohol and smoking. So that's what led him to a gastric ulcer condition versus a duodenal ulcer. Okay, so that was a little challenging, but one maybe you'll remember now. The upper GI bleed, again, it can happen suddenly, and sometimes too it's coming from the esophagus area or something called a Mallory-Wise tear, which I think that's spelled wrong though. I think it's W-E-I-S. I have to go back. But that's due to a person who may be vomiting profusely, like somebody who's abusing alcohol, and they're having morning, vomiting episodes, severe, and the same thing with someone who might be bulimic, and they're forcing themselves to vomit. So we have to look to see why this is happening, but of course it's an emergency at the time, so they might be taken in for an endoscopy and cauterized. It will repair itself, but not if the behavior continues. So that's why it can be a source of significant bleeding. All right, and here's some of the medications for treating that too. The pyloric stenosis, so we know that's going to be detected once a child is forcefully vomiting. So that projectile vomiting is usually telltale. For something is narrowing, the sphincter, the pyloric sphincter is not opening. It's completely a stricture going on down there. Okay, so now for lower GI, just want to keep in mind with diarrhea, constipation, how we're monitoring fluid and electrolyte. With children, you don't want to necessarily give Lamodal. That wouldn't be appropriate. And we're careful to treat the symptoms of diarrhea right off the bat. We might want to let it take its course, but of course, if it's severe, we do want to take care of that as well. We don't want to let it go on. And also for fluid and electrolytes, risk for dehydration is high. If someone starts to get lethargic, or that's why we do have to really watch, because replacing fluids is a priority, and watching so that the person stays conscious. We don't want them to slip into unconsciousness, syncopal. Constipation also is an issue with much of America because we don't exercise enough, we don't eat enough fiber, so that should really be the priority. And then don't want them to get dependent on stool softeners or laxatives, because they can become habit forming and then the gut gets lazy. So those are really for just kind of emergencies. We're not supposed to be using them routinely. I had a patient once who was taking mineral oil, which we took off the floors many years ago, over 2 decades ago, and I happened to be in his living room, talking to him as a visiting nurse, and I saw it in the corner, and I said, "Who's using mineral oil?" And the man said he was. And so I said, "Not after today. You're not going to use it anymore. Please tell me you'll stop." And nobody had ever talked to him about this. I said, "But all the medication that you keep getting bumped up higher and higher dosages." He had a very bad COPD and some cardiac issues. And he was going to his doctor that same day. So I said to him, "Listen, talk to him about if you can be on Miralax here." And I had a sample. I just happened to have one. So I said, "Here, take this, but you are not to use that mineral oil anymore." And sure enough, the doctor said, "I wish I knew this 25 years ago." So that's where you have to go into the home sometimes and see what people are doing. And in my follow-up visit, he was mad at me because I took away his go-to. Literally, it helped him go. But I said to him, "Yeah, but now your medications can come down in dosage, and you can actually absorb some of them because mineral oil blocked absorption of medications." So, we could never drill down and talk to people enough about this stuff. That's all I can say. 25 years, a lot of wasted money, unnecessary suffering, all because he used mineral oil. Okay, so irritable bowel syndrome, again, we're talking about a condition that most of the time, lifestyle, we have to look at that, see how we can fix some of the coping of this person and how their self-care is, and then hopefully it'll abate itself. But it's something that can really wreak havoc in people's lives. Appendicitis, this is where this is a medical emergency, and the symptoms, again, can start around the belly and then go to the right lower quadrant. That's more the classic presentation, but it can also perforate and create emergency, which the next slide talks about, peritonitis. So we want to avoid that. These are all lower GI, right? So if somebody develops peritonitis, they're going to be taken into surgery. You're not going to feed them. You're going to make sure that they have some antibiotics going in. They probably have an NG to low suction and pain medication, oxygen, all of that, because this is truly a life-threatening condition, and the body's on using all of its resources to try to survive this. In surgery, they usually lavage out the peritoneal cavity and try to remove the infection that's in there, and then the rest of it's time for this person to heal. And they will have a protracted hospitalization due to this. It's not going to be like the appendectomy where they're in and out in 24 hours. No, they're going to be in there longer. Okay, inflammatory bowel. This is something that's getting more serious than IBS. We're talking about ulcerative colitis that can lead to Crohn's if it's not treated early enough and lifestyle changes aren't made. And sometimes there are infections that can cause this. It's not always due to just autoimmune. There's people that can develop, I believe, like neurovirus can lead to things like this, or, just even forms of, hepatitis, which can inflame the whole bowel, So there's times that people can get things and it takes them a long time to recover. It could become chronic. So that's why we really want to be giving support and education to people to stay in a good relationship with their doctors, stay on medications, and try to avoid surgery, try to keep them out of the hospital if possible. Now, the diverticular are those little out patches in the large intestines that happen usually due to not having enough exercise and fiber. So colonoscopy detects that, and that's where we want to make sure that people get it early enough. Age 50 is recommended, but sometimes 45 is appropriate too if they're having a lot of symptoms. Okay, so if they've got diverticulosis, they're going to have to make some lifestyle changes and get some fiber and get moving and just get a healthier diet. But if it starts to get inflamed, they do need to understand that diverticulitis is, again, another medical emergency. They might be able to avoid hospitalization through antibiotics, but if one of those diverticuli rupture and perforate, they're going to have surgery. Okay, intestinal obstructions. These are described in your book too as things that can be non-mechanical or mechanical. And if they're non-mechanical, you have to think, okay, what could be causing obstruction? And sometimes you have adhesions. You have things that happen that years ago, especially when people had a lot of abdominal surgeries. But for the most part, just know that it is a cause of an ileus, paralytic ileus. If you hear of some, it's the intestine is not moving. There's no peristalsis happening. So that's a very serious condition. You have to not feed that person. Many times expect to put an NG tube in and try to restore peristalsis. That's the goal. But of course, if there's an obstruction going on, you'd have to try to get that clear before you can help the peristalsis come back. So with all of these things, they need to be watched and diagnosed, and also there may be surgery as a result. They may have to have the obstruction, like if it's a tumor, then they'd have to have a colectomy, and usually there's a reanastomosis. So, with all these things that you're saying, it's going to be with a resection, bowel resection, that's usually, if it's not within 24 hours, relieved. So they don't want to do it as a first effort, but if they come to the hospital, we're looking to do what we can, and sometimes, just giving the body a chance with supportive measures can actually help it resolve on its own. I've heard of cases of people with MS that developed this, and just again, putting them on a lighter diet, clear fluids, IV hydration, it did resolve on its own. Okay, the other is the Hirschsprung disease, which can also cause obstruction, and this is something usually on birth it's detected because they don't pass the meconium stool within the first 48 hours. Otherwise, it can happen a little later, but that's where the megacolon, and it's all about the innervation to the bowel. Peristalsis is not happening. It can be resolved with time and diet and care, but it is something that has to be monitored and usually picked up on x-ray. Okay, and hernias, be aware of the, inguinal is the more common for men. There also is an umbilical hernia and ventral hernias, which are more central abdominal, and they also require repair, especially if they are advanced extrangulated types hernias. Pediatric hernias, the diaphragmatic, facile, and you just look at the word seal, meaning it's encased. It's like the intestines are protruding through the abdominal wall, but they're kind of still in the sac. Where the gastroexesis is, it's completely out. The intestines are totally out of the body. Diaphragmatic is they're up in the diaphragm, the intestines. So these are all things that have to be repaired surgically, otherwise it's not conducive to life. And that's all we need to talk about at this point. All right, so I'm going to end here, and I thank you for listening. And I'm sorry, but I had some trouble recording earlier, so I had to do it a couple of times to get it to this point. Thanks for listening. See you during the week.